Namaste to all of my friends. Welcome to Nephro Study Hub. Today we are going to learn about plasmapheresis. So what is plasmapheresis? Plasmapheresis is a process where plasma is separated from the blood. That is called plasmapheresis. But only that is plasmapheresis? No. The main thing is therapeutic apheresis. So what is therapeutic apheresis? It refers to a group of extracorporeal process which blood separation technology is used to remove abnormal blood cell and plasma constituents. That means blood is separated in a extracorporeal circuit and it is divided in two parts, plasma and blood cells. So there are different type of therapeutic apheresis. First one is plasmapheresis, second one is erythropoiesis, third one leukapheresis, thrombocytopheresis, lipoproteinpheresis, etc. So why I am telling that etc. because therapeutic apheresis is divided in many parts. So we need a video on therapeutic apheresis. Later I am going to make a video on that topic. So today we are going to know about the few type of therapeutic apheresis. The first one is plasmapheresis. Second one is erythrocytopheresis. So what is this? It is a treatment where RBC is separated. The third one is leukapheresis. This is the process where white blood cells are separated. Fourth one, thrombocytopheresis, means where platelet are separated. And lipoproteinpheresis, in this process we are going to separate the LDL cholesterol from the blood. So now it is easy. Main thing is therapeutic apheresis, which is divided in different part, and we are going to know about plasmapheresis. Let's go to section in plasmapheresis. Plasmapheresis. In theory, we can say that it is an extracorporeal medical procedure where specialized machine separate and extract the liquid part of blood called plasma from its cellular component, red blood cell, white blood cell and platelets. Now what is therapeutic plasma exchange or TPE or PLEX? We usually can hear the term PLEX. So in plasmapheresis, plasma is separated. It can be in blood bank where a plasma donor is came, or we need some plasma from a patient. So plasmapheresis can be done. But if it is done for any medical condition like to remove harmful antibodies, toxin, abnormal proteins, and then we replaced that plasma volume with replacement fluid, then it got called therapeutic plasma exchange, TPE or PLEX. So now we know that what is plasmapheresis and what is therapeutic plasma exchange. Plasmapheresis or therapeutic plasma exchange are done in various type of patients with various conditions. There are the few indications of plasmapheresis. The first belongs to hematological condition. First one is TTP, thrombotic thrombocytopenia purpura. Second one, hypervascularity syndrome. Third one, sickle cell. Fourth one, hyperleukocytosis, thrombocytosis. Indication of plasmapheresis from neurological disorder. First one is Guillain-Barré syndrome. Second one, Myasthenia Gravis. Third one, autoimmunoencephalopathy. Plasmapheresis due to indication in renal disorder. First one, Guillain-Barré syndrome. Second one, rapidly progressive glomerulonephritis. Third one, recurrent focal segmental glomerulosclerosis. Some other disorders: severe cryoglobulinemia, pulmonary and Neller syndrome, antibody mediated rejection, acute liver failure. Number 5, severe hypertriglyceridemic pancreatitis. Technical methods done in plasmapheresis. So, plasmapheresis or therapeutic plasma exchange is done by two types. The first one is centrifugal apheresis. The second one is membrane plasma separation. So, first one is done by blood bank and the second one is done by nephrology department. So, in that picture, we can see that blood came from patient body, passes through a centrifuge machine where patient plasma is separated, then the blood with high concentration return to patient body. Replacement fluids are added in the return line. Calcium gluconate injected due to cited anticoagulation. Second one, membrane plasma separation by nephrology department. Blood came from patient body, anticoagulation added, pre-blood pump, then blood passes through plasma filter where plasma is separated, then blood return to patient body. In that line, we use replacement fluid to add. A calcium gluconate injection infused in the return line to maintain the calcium level in body due to use of cited anticoagulant. So, in that picture, we can clearly see that cited is mainly used as an anticoagulant in centrifugal apheresis, and heparin also can be used, and in membrane plasmapheresis we use heparin and cited also can be used. The both process of doing plaques are different, especially a centrifugal separation use density difference. Whole blood spins in a rotor bowl, means a cylinder type structure with which spin around, then all the component of blood are separated by the density. High density cells like red blood cell pack against outer world, while low density plasma stays near the center of for extraction. If we can see in that photo, in this lower part red blood cells are there, the second part white blood cells are there, third part platelets are there, and the fourth part plasma are there, and we can collect all of those things one by one. First one for red blood cell, second one for white blood cell, third one for platelet, and fourth one for plasma. Now, membrane plasma separation. Use size exclusion. Blood flows to a hollow fiber microporous membrane like hemodialysis. Blood passes through those membranes. A positive pressure gradient pushes the smaller liquid plasma molecule through pores while retaining larger cellular elements. So, if we can see that photo, it is an hollow fiber membrane. Blood passes through this. There are some holes. Holes can be sized 0.2 micrometer to 0.6 micrometer or 200 to 600 nanometer. So you can compare that a plasma filter pore size is 200 nanometer and a hemodialysis high flux dialyzer pore size is 3 to 6 nanometer. Blood passes through this membrane and the molecules smaller than that hole passes through the membrane to the plasma compartment of plasma filter like cholesterol, albumin, sodium, potassium, urea, creatinine, glucose, immunoglobulin A, immunoglobulin AM, fibrinogen, etc. We collect those plasma with those cells in a jar. So this is the main process, plasma separation by membrane. Membrane plasma separation, extracorporeal volume and flow rates. So in this part we are going to know about the technical aspects of membrane plasma separations by a nephrology department. So TCB threshold, fluid volume outside the body must strictly remain under 15% of patient's total blood volume to prevent hypovolemic shock. So in this line they are saying that if a patient blood volume which we can measure by the 70 ml per kg. So if a patient of 60 kg weight, the blood volume is going to about 4.2 liter. So 15% of that volume can be in extracorporeal circuit, not more than that volume. We in membrane separation, the blood volume from in the extracorporeal circuit is much less than that volume. It is likely 150 ml to 120 ml in blood tubing or 50 to 80 ml in plasma filter. So total around 200 to 250 ml. Second one is blood flow rate, typically maintained between 50 to 150 ml depending on the vascular access stability. So blood flow rate depends on vascular access stability and also in TMP, because if TMP excessive, then blood RBC cells can enter in the plasma section. Third, plasma filtration rate, controlled strictly to prevent exceeding the filtration fraction unit 20 to 30% of QB. So plasma filtration rates must be 20 to 30% of blood flow rate, which prevents severe hemoconcentration inside the filter. If we remove more than that volume, then the concentration in the filter is going to be very high, and that can start a clotting factor in that hemofilter. So in this photo we can see a filter. Here the blood enters in the filter, and from there the blood comes out, and the plasma is separated through the membrane and came outside from this pore. Now we are going to know some specifications about plasma filter. We already seen a Fresenius company filter, plasma filter called P1 or P2. So these are some specification of that filter. The first one is plasma filters are a hollow fiber bundle layout. We all know that, made with polyether sulfone, polysulfone. It is like a hemodialyzer membrane. Second one is effective surface area 0.3 to 0.6 meter square. So it is less than the hemodialyzers, which are typically from 1.2 1.3. We can also know that 0.8 meter square F4, but it starts from 0.6 to 2.0 meter square. Blood flow rate 80 to 250 ml per minute. Here I can tell you that typically blood flow rate mentioning is 50 to 150 ml per minute. Maximum transmembrane pressure is 80 to 100 mmHg. In hemodialyzer we can see that maximum TMP can be 500 to 600 mmHg, because the pore size, here are the pore size of the membrane is much higher than the hemofilter. In number 6 point we can see that pore size of a plasma filter can be 200 to 600 nm, where in dialyzer we can find maximum 10 mm. Number 5, filling volume, blood side 50 to 70 ml, plasma side 125 ml. Number 7, housing or potting, polycarbonate housing with polyurethane potting. Sieving coefficient 1.0, which means molecular like albumin, immunoglobulin G and immunoglobulin A passes across the membrane entirely unobstructed. Number 9, hollow fiber inner diameter usually 200 to 350 micrometer, which means we can see in this photo that the inner diameter is written 200 micrometer, which can be 350 micrometer also, and the wall thickness is 20 to 50 micrometer. In this photo we can also see that thing. So till now we know the indication of plasmapheresis, the technical aspect of plasmapheresis, the plasma filter. Now we are going to know about the some replacement fluid in the therapeutic plasma exchange. First one is human albumin, 4 to 5%. The most common replacement fluid, it is widely available, carries a low risk of allergic reactions and is highly effective at maintaining oncotic pressure. So in the world everywhere we can use albumin. Second one is fresh frozen plasma. Specific conditions like thrombotic thrombocytopenia purpura, as it replenishes deficient clotting factors and proteins. Because it comes from human donor, it carries slightly higher risks of allergic and anaphylactic reaction. So if we use fresh frozen plasma, then allergic and anaphylactic reactions can be happen. But in thrombotic thrombocytopenia purpura, plasma is separated where antibodies and proteins are also passes through the membrane. So we have to use the fresh frozen plasma to maintain the protein because it come from the human donor. Crystalloids. Isotonic solution like normal saline or ringer lactate are usually when combined with albumin sometime. Colloid. Sometimes colloid are also used. Hydroxyethyl starch occasionally used. And human amyl also a colloid in medical term. We can see the photos of every replacement solution in that page. So today I stop this class at this point, and the part 2 we are going to know about the complication, contraindication of plasmapheresis and some other points too. So stay on the channel for the part 2 of plasmapheresis.